Welcome to the deep dive. Today, we're embarking on a journey into one of your body's most remarkable systems. Really tireless. The renal and urologic system.
That's right.
Think of your kidneys as like your body's master environmental engineers, constantly cleaning, balancing.
Making critical adjustments, yeah, keeping everything running smoothly.
Exactly. And for this deep dive, we're pulling our insights from Understanding Pathophysiology, 7th edition.
By Huether, McCants, Brashers, and Rote, a solid source.
Our mission to really unpack the intricate design and, the incredible capabilities of your kidneys and the whole urinary tract. Hopefully you'll walk away with a real appreciation for these unsung heroes.
It truly is a pivotal system, and, the kidneys do far more than just filter.
Right.
They are absolutely central to maintaining a stable internal environment, balancing water and solutes, getting rid of metabolic waste.
Regulating acid-base balance, too.
Precisely. And what's often overlooked is their endocrine function. They secrete hormones, like renin, for blood pressure. Erythropoietin, that's for red blood cell production. And they even activate vitamin D3 for calcium metabolism.
So ultimately, we're talking about the complex process of, urine formation, which happens through 3 basic steps, right? Glomerular filtration.
Tubular reabsorption.
And secretion.
That's it.
Okay, so let's break down how all these pieces work together, this constant internal tune-up that's just vital for your health. All right, structures of the renal system. To understand the genius here, let's map out the key players, starting with the kidneys themselves.
Okay.
Imagine 2 bean-shaped organs, roughly the size of your fist, tucked away deep in your back, kind of below your ribs on either side of your spine.
Posterior abdominal cavity, behind the peritoneum.
Right. And the right one's usually a little lower, isn't it? Because of the liver.
Exactly. Nudged down by the liver. They're well protected, too. Renal capsule, fat, fascia.
And if you picture, say, figure 31.1 from the text, you see this overall layout, the kidneys up high, then the ureters, these tubes running down.
Connecting to the bladder.
Which then empties out through the urethra. It's a really neat interconnected network.
It is. And internally, the kidney is structured for, maximum efficiency. If you sliced one open, like in figure 31.2, you'd see an outer layer, the cortex.
Okay.
And an inner region, the medulla. The medulla has these distinct pyramid-shaped sections.
Pyramids, right.
And these pyramids point inwards towards these small collecting chambers called minor calyces.
Minor calyces.
Which then merge into larger major calyces.
Yes.
And those funnel into the renal pelvis.
Which is basically the top of the ureter, like a funnel.
Exactly, the expanded upper end of the ureter. And at the kidney's indented side, the hilum, that's where everything connects.
Yeah.
Blood vessels, nerves, the ureter.
Got it. Now let's zoom right in. The true workhorse, the nephron.
Ah, yes, the functional unit.
Each kidney has about 1.2 million of these tiny things.
It's incredible.
Think of a nephron like a microscopic processing plant. It's this tiny, intricate tubule with several parts. If you look at figure 31.3, it shows the sequence. Starts with the renal corpuscle.
That's the filtering bit.
Then it winds through the proximal tubule, dips down into the loop of Henle, like a hairpin. Then the distal tubule, and finally empties into a larger collecting duct.
And this whole winding path is where blood purification really happens.
But they're not all the same, are they, these nephrons?
No, that's a key point. Most are superficial cortical nephrons. They only dip slightly into the medulla. But crucially, about 12% are juxtamedullary nephrons.
Juxtamedullary, okay.
They lie deeper, close to the medulla, and their loops of Henle go way down, maybe 40 millimeters.
Wow!
And these deep loops are absolutely essential for the kidney's ability to concentrate urine, conserving water.
That makes sense. Okay, let's focus on that starting point, the renal corpuscle, the filtering station.
Right, where plasma first gets separated.
It includes the glomerulus, that's the tuft of capillaries, right?
A dense little knot of capillaries, yes, and the Bowman capsule that surrounds it.
The text describes it like a fist pushed into dough.
That's a great analogy. The glomerulus is the fist, the Bowman capsule is the dough wrapping around it.
And there are other cells in there too, mesangial cells.
Yes, mesangial cells. They're important support cells. They secrete matrix, act like immune cells, and can even contract to regulate blood flow right within the glomerulus.
So quite complex.
Very. Now, the actual filter, the glomerular filtration membrane, it's a marvel.
3 layers.
3 specialized layers.
Right.
If you imagine a cross-section, like in figure 31.5b, you have the intercapillary endothelium with pores, a middle basement membrane, and an outer layer with these unique cells called podocytes.
Podocytes, foot cells.
Kind of. They have these foot-like projections, pedicles that interlock, creating tiny gaps called filtration slits.
Okay.
And these layers are coated with negative charges.
Why negative?
That actively repels negatively charged proteins in the blood.
Ah, so that's why proteins don't usually get filtered out.
Exactly. This design allows water, electrolytes, small molecules through,
Yeah.
but blocks blood cells and most proteins, forming that initial filtrate.
And controlling this filtration, there's the juxtaglomerular apparatus.
Yes, a specialized site right where the distal tubule touches the afferent arteriole supplying its own glomerulus.
A feedback loop.
Precisely. It has renin-releasing cells, sodium-sensing cells, macula densa, and those mesangial cells. It constantly monitors and adjusts blood flow and filtration.
Incredible control. Okay, let's follow that filtered fluid, the filtrate, through the nephron tubules. First stop, the proximal tubule.
Right. This is where the bulk of reabsorption happens.
And it has that special lining, the brush border.
Yes. If you look at figure 31.6, which shows the different epithelial cells, the proximal tubule cells have this dense brush border of microvilli.
Like a carpet.
Exactly. Dramatically increases the surface area. This is where about 60–70% of the filtered sodium and water get pulled back.
Along with almost all the glucose, amino acids, bicarbonate, the good stuff.
All the essential molecules your body wants to keep.
Then comes the loop of Henle dipping into the medulla.
Right. Different parts do different things. The thick ascending limb actively pumps out salts, but not water. The thin descending limb lets water out passively.
Setting up that concentration difference we talked about.
Yes. Then the distal tubule and collecting duct make the final, precise adjustments.
Fine-tuning.
Exactly. Specialized cells here reabsorb sodium, secrete potassium, secrete hydrogen ions, reclaim bicarbonate,
Wow.
all critical for balancing fluids, electrolytes, and pH.
And all these nephrons need blood, obviously. The kidney's blood vessels are closely linked.
Intricately linked. Figure 31.4 shows this well. Blood comes in the renal artery, branches down, interlobar, arcuate.
To the afferent arteriole feeding each glomerulus.
Then filtration happens in the glomerular capillaries. Blood leaves via the efferent arteriole
And goes where?
into the peritubular capillaries that surround the tubules. This is where reabsorbed substances re-enter the blood.
Right, wrapping around the tubules.
And a really vital part is the visa recta.
Ah, those hairpin loops.
Yes. Following the loops of Henle deep into the medulla. It's the only blood supply there and crucial for concentrating urine.
Got it. Then blood collects in veins and heads back out. Okay, beyond the kidneys, the urinary structures, transport and storage.
Right. Urine flows from collecting ducts, through the calyces, into the renal pelvis, then down the ureters.
How long are the ureters?
About 30 centimeters in adults.
Oh,
Muscular tubes. They use peristalsis, wave-like contractions to propel urine down.
Like the digestive tract.
Very similar. And the way they enter the bladder, obliquely through the wall, acts like a valve. Prevents reflux.
Smart design. What about the bladder? Figure 31.7 shows its structure.
It's a muscular bag. The main muscle is the detrusor muscle, lined with special uroepithelium.
Uroepithelium.
Yeah, it's amazing. It stretches as the bladder fills, but it's also a barrier, preventing water and solute linking back into the blood. And it even signals pressure changes.
Wow. And the urethra is the exit tube?
Right. Extends from the bladder outwards. There's an internal urethral sphincter, smooth muscle, involuntary.
And an external one.
Yes, the external urethral sphincter, skeletal muscle. That's the one under your voluntary control.
Which allows for the maturation reflex, or urination.
Exactly. When the bladder fills to about 250–300 milliliters, stretch receptors fire, spinal reflex contracts the bladder, relaxes the internal sphincter. You feel the urge.
But you can consciously override it?
Your brain can inhibit or facilitate that reflex via the external sphincter,
Yeah.
giving you control.
Okay, let's shift gears. Renal, blood flow, and glomerular filtration. You mentioned kidneys get a huge amount of blood.
Astonishing amount. 1,000 to 1,200 milliliters per minute. That's 20–25% of your total cardiac output.
Incredible. Just shows how vital filtration is.
Absolutely. And about 20% of that plasma gets filtered at the glomerulus. Roughly 120–140 milliliters per minute.
And that rate is the glomerular filtration rate, GFR.
Exactly. The gold standard measure of kidney function.
And it's tied to blood pressure in those capillaries.
Directly. If your main arterial pressure drops or vascular resistance goes up, renal blood flow, RBF, falls, and so does GFR and urine output.
But the body tries to keep it stable, right? Autoregulation.
Yes. This is fascinating. The kidney keeps GFR pretty constant, even if your systemic blood pressure swings between, say, 80 and 180 millimeter Hg.
Figure 31.8 shows this graphically. RBF and GFR stay relatively flat over a wide pressure range.
It's essential for consistently clearing waste and reabsorbing nutrients.
How does it do that? Two mechanisms.
Two main ones. First, the myogenic mechanism. If pressure rises in the afferent arteriole, the muscle in its wall stretches and automatically contracts.
Increasing resistance, keeping flow steady.
Exactly. And the opposite happens if pressure drops, it relaxes. Second, tubular glomerular feedback.
Involving the macula densa cells again.
Right. They sense sodium chloride in the distal tubule filtrate. If GFR is too high, meaning lots of sodium flows past,
They signal back.
they signal the afferent arteriole to constrict, reducing GFR back towards normal. It's a beautiful feedback loop.
Amazing. Is there nervous system control too? Neural regulation?
Yes, sympathetic nerves innervate the kidney vessels, mainly the afferent arterioles.
So stress response.
If your systemic pressure really drops, sympathetic nerves fire, release catecholamines.
Constricting those arterioles.
Yes, it reduces RBF and GFR, but importantly, it also increases sodium and water reabsorption to help bring systemic blood pressure back up.
And hormones play a big role too. The renin-angiotensin-aldosterone system,
RAAS.
a major player. RAAS activation significantly increases systemic blood pressure and modifies RBF.
Renin gets released from.
Those juxtaglomerular cells. Triggered by low blood pressure in the afferent arteriole, low sodium chloride at the macula densa, or sympathetic stimulation.
And RAS has multiple effects.
Oh yes, sodium reabsorption, systemic vasoconstriction, stimulating sympathetic nerves, even making you thirsty, all aimed at raising blood pressure and fluid volume.
And aldosterone is key here, working with ADH.
Right, figure 31.9 illustrates this nicely. Low blood pressure triggers both. ADH makes the collecting ducts permeable to water, pulling water back. Aldosterone, stimulated by RAS, tells the distal tubules and collecting ducts to reabsorb more sodium.
And water follows the sodium. Exactly. It's a coordinated effort to restore volume.
But there's an opposing system, natriuretic peptides.
Yes, AMP and BMP from the heart. They're natural antagonists to RAAS.
So they make you excrete sodium and water.
Correct. They cause vasodilation, inhibit sodium-water absorption, inhibit renin and aldosterone. This lowers blood pressure, protecting the heart from overload.
Okay, let's get into the real nitty-gritty, kidney function. What the nephron actually does. Urine formation.
It's a multi-step process. Figure 31.0 gives a great overview of what each nephron segment does, filtering plasma at the glomerulus, reabsorbing and secreting along the tubules.
Regulating the filtrate to maintain body fluid volume, electrolytes, pH, all within tight limits.
Right, and just to clarify terms again, figure 31.1 shows this flow. Glomerular filtration, blood to tubule,
Okay,
tubular reabsorption, tubule back to blood.
got it.
Tubular secretion, blood directly into tubule.
And excretion, out in the final urine.
Exactly. Filter, reabsorb, secrete, excrete.
So glomerular filtration, the fluid entering Bowman capsule, is like protein-free plasma?
Essentially, yes. Water, electrolytes, glucose, urea, creatinine, all are plasma concentrations. But no large proteins or cells.
Because of that selective filtration membrane, size and charge matter.
Absolutely. And a pressure's driving it. We mentioned hydrostatic pressure pushing out.
And oncotic pressure pulling back in. Figure 31.12 details these pressures.
Right. The main force favoring filtration is the hydrostatic pressure inside the glomerular capillaries. Opposing it are the hydrostatic pressure in Bowman space and the oncotic pressure from proteins still in the capillary blood.
The net difference is the net filtration pressure, NFP.
Yes. And as fluid filters out, the protein concentration inside the capillary rises, increasing oncotic pressure.
So NFP decreases along the capillary.
It does, eventually falling close to zero at the efferent end, stopping filtration there. This also helps drive reabsorption later in the peritubular capillaries.
And the rate is huge, 180 liters a day filtered.
Phenomenal, but we reabsorb over 99% of it.
What happens if urine outflow is blocked, like with a kidney stone?
Good question. Pressure backs up into Bowman space, opposing filtration, so GFR decreases.
And low plasma protein.
That decreases the oncotic pull back into the capillary, so GFR can actually increase.
Interesting. Okay, moving down the tubule, the proximal tubule. Bulk reabsorption happens here.
Yeah, that's right. 60–70% of sodium and water, 90% plus of glucose, bicarbonate, amino acids.
Potassium, calcium, phosphate.
All actively pulled back into the blood. Chloride, water, and urea follow passively, often linked to sodium movement.
But there's a limit for some things. Transport maximum,
Yeah.
TN.
Carrier molecules can get saturated. Glucose is the classic example.
If blood glucose is too high.
The carriers in the proximal tubule get overwhelmed. They can't reabsorb it all, so the excess spills into the urine, glucosuria.
And bicarbonate reabsorption is crucial here too, for pH balance.
Absolutely vital.
Yeah.
About 90% is reclaimed in the proximal tubule through a process involving hydrogen ion secretion and the enzyme carbonic anhydrase.
The tubule also actively secretes things.
Yes, secretory transport mechanisms. For creatinine, organic bases, organic acids like penicillin, PAH, Box 31.1 lists many examples.
So getting rid of drugs and waste products.
Critical for eliminating certain substances. If tubules are damaged, these can build up.
And this balance between filtration and reabsorption is automatic. Glomerular tubular balance.
Yes, if GFR changes, the proximal tubule adjusts its reabsorption rate proportionally, a key stabilizing feature.
Now, the loop of Henle and distal tubule. Fine-tuning urine concentration.
This is where the countercurrent exchange system works its magic. Figure 31.13 illustrates it.
Fluid flowing in opposite directions in parallel tubes.
Exactly. The loop of Henle multiplies a concentration gradient, and the vasa recta maintains it,
Let's walk through it. Thick ascending limb pumps out salt, but not water.
making the surrounding medulla very salty, very hyperosmotic, and the fluid in the tubule becomes dilute.
Then the descending limb, permeable to water.
As filtrate flows down, water gets pulled out into that salty medulla, making the filtrate inside increasingly concentrated.
Creating that gradient from cortex to deep medulla.
Precisely. And the vasa recta, with its slow flow and hairpin shape, exchanges salt and water to preserve that gradient, doesn't wash it out.
So if blood flow there is too fast,
Gradient gets washed away, ability to concentrate urine is lost, which happens in some kidney diseases.
and urea recycling contributes to this gradient too.
Significantly, about half is excreted, half is recycled within the medulla.
The distal tubule and collecting duct make the final call on water, controlled by ADH.
Yes, ADH makes these segments permeable to water. If ADH is present, water is reabsorbed, urine becomes concentrated. If ADH is absent, water stays in, urine is dilute.
And aldosterone controls sodium reabsorption here and potassium secretion.
Correct. Final electrolyte tuning. And also hydrogen ion secretion for acid-base balance.
So normal urine composition, clear yellow amber, pH usually acidic, specific gravity 1.001-1.035.
And crucially, no glucose, blood cells, or significant protein. Table 31.1 lists normal values and what abnormalities might mean, like bacteria suggesting infection or casts suggesting kidney tubule issues.
Let's talk hormones and nephron function. We mentioned antidiuretic hormone, ADH.
Released from the posterior pituitary. Acts on the late distal tubule and collecting ducts.
Job is to increase water permeability.
Exactly. Opens water channels, aquaporins, allowing water to be reabsorbed back into the blood via the vasa recta. This is how you make concentrated urine and conserve water.
Then aldosterone, from the adrenal cortex, part of RAAS.
Stimulates sodium reabsorption in the distal tubule and collecting duct. Water follows passively.
Also increases potassium and hydrogen excretion.
Correct. Key for electrolyte balance.
And the opposing team, natriuretic peptides, ANP and BMP from the heart.
They do the opposite of RAS. Promote sodium and water excretion.
How?
Inhibit sodium-water absorption in tubules, inhibit renin aldosterone, cause vasodilation in the kidney, lowers blood volume and pressure.
Protects the heart from overload.
Exactly. And there's also urodelatin, a similar peptide made right in the kidney tubules.
And diuretics work by interfering with sodium reabsorption.
Generally, yes. Different types work on different parts of the nephron to increase urine output. Useful for hypertension, edema, but can cause dehydration, electrolyte issues.
The kidney also makes or activates hormones itself, vitamin D.
Crucial step happens in the kidney. Inactive vitamin D needs hydroxylation first in the liver, then the kidney to become active.
And that step is stimulated by parathyroid hormone, PTH.
Yes, when calcium is low. Active vitamin D then helps absorb calcium from the gut and kidney. People with kidney disease often lack active vitamin D.
Leading to calcium phosphate problems. And erythropoietin, EPO,
Made in the kidney in response to low oxygen levels.
hypoxia, tells bone marrow to make red blood cells.
Exactly. This is why chronic kidney failure often causes anemia and not enough EPO production.
Wow. So kidney health impacts blood count directly.
Directly. And EPO has other protective effects too beyond red blood cells. Anti-inflammatory, tissue repair.
Okay, how do we actually measure kidney function? Tests. Renal clearance.
Techniques to see how effectively the kidneys remove a substance from the blood over time. Let's just estimate GFR, RBF, tubular function.
And GFR is the best overall measure.
Considered the best estimate of functioning renal tissue. Crucial for diagnosis, staging disease, dosing drugs.
Clinically, creatinine clearance is common.
Very common. Creatinine is a muscle breakdown product, made constantly, freely filtered. Requires a blood sample and a 24-hour urine collection.
It slightly overestimates GFR.
Because a small amount is secreted by tubules, but it's usually close enough for clinical use.
What about cystatin C?
Another marker, a protein filtered by the glomerulus. Serum levels are increasingly used to estimate GFR, especially for milder impairment.
And just measuring plasma creatinine, PCR itself.
Also very useful, especially for monitoring chronic disease. PCR and GFR are inversely related.
So if GFR halves, PCR roughly doubles.
Approximately, yes. But it takes days for PCR to stabilize after a change in GFR, so it reflects a more chronic picture. Normal is around 0.7 to 1.2 milligl.
Blood urea nitrogen, BUN, too.
Yes, BUN reflects GFR and urine concentration. Increases as GFR drops, but also increases with dehydration or high protein intake as urea reabsorption changes. Normal is 10-20 milligl.
And urinalysis, simple but powerful.
Absolutely. Non-invasive. Checks color, clarity, pH, specific gravity, looks for protein, glucose, and sediment under the microscope.
Sediment can show cells, bacteria, casts, crystals, all clues. Table 31.1, again, highlights these findings.
Exactly. Red cells might mean bleeding, white cells infection, casts suggest kidney tubule problems.
Okay, briefly, special considerations across the lifespan. Pediatrics.
Newborn kidneys aren't fully mature. GFR reaches adult levels around age 1 or 2.
So they handle water and solutes less efficiently?
Yes, and they can't concentrate urine as well due to shorter loops of Henle, narrower safety margin for fluid balance.
Higher risk for acidosis, too.
In the first few months, yes. Acid excretion isn't fully developed, so things like diarrhea can cause bigger problems.
And geriatric considerations, aging kidneys.
There are structural changes, loss of mass, hardening of arteries, fewer functioning glomeruli and tubules.
Leading to a slow decline in GFR.
Usually a gradual decline in healthy older adults, but functional reserve decreases.
Meaning they handle stress less well, dehydration or fluid overload.
Correct. Ability to concentrate urine decreases. Responses to acid-based changes are slower. Drug elimination can be impaired, increasing risk of toxicity.
And other conditions like hypertension or diabetes speed this up.
Significantly accelerate the decline.
All right, let's wrap this up. Outro. So what's the big picture here? We've really dug into the incredible complexity and, frankly, the vital role of your renal and urologic systems.
Yeah.
From those millions of tiny nephrons filtering constantly to the sophisticated hormonal balancing act. It's just amazing biological engineering.
It really underscores how structure and function are so tightly linked, and how many different systems have to work together perfectly.
Yeah, homeostasis.
Understanding these mechanisms isn't just, academic. It's key to appreciating how your body stays healthy, how resilient it is, and why small changes, like in fluid balance, can have such big systemic effects. Hopefully, this gives everyone a real appreciation for these unsung heroes.
Absolutely. We hope this exploration has painted a clearer picture for you. Maybe left you with a few surprising facts. Next time you take a drink of water, think about the amazing work your kidneys are doing, tirelessly behind the scenes.
Constantly adjusting.
Thank you for joining us on the deep dive. Keep that curiosity flowing, and we look forward to our next exploration together.